Thank you. Well, thank you, Russ. It really is a great privilege to be here today. As a young scientist doing a PhD, the BSP was the first place I ever gave a scientific talk to, and it's a society that I've held in very high regard for a long period of time. It's a particular honor to be here for David today. I was introduced to David by Vaughan Southgate, I think at a BSP meeting, probably late in the evening, the worse for wear. And David and I got to know each other, and then we edited a volume on the ecology of parasites for the BSP a long time ago, in the 1970s, I think it started. So it is a particular privilege, David, to be here. And I followed your very distinguished scientific career for a long time, and we look forward to hearing about bits of it today. Now, what I'm going to talk about is essentially some of the NTD work, which is about progress towards control of particular infections. And do remember, I come to this as starting life as an ecologist stroke parasitologist, so I come to it from the concept of population biology. I want to, first of all, look at some data on recent progress and MDA coverage and make some comments about how the statistics are recorded. I'm then going to turn quickly to the basic epidemiological principles, because sometimes we forget one or two of them. I then want to turn to this complicated issue about breaking transmission and its definition, which of course is very related to spatial scale and so forth. And then issues which WHO has been considering quite carefully for the helminths, which is at what prevalence do you stop MDA and how long do you then monitor it thereafter? And then I'm going to turn to what is, in my view, the most important issue of all, which is compliance to treatment, before I conclude. Now, my first involvement in this was through Rockefeller Foundation by Ken Warren, who kindly gave me a grant to try and measure some population parameters for Ascaris. And these two remarkable young individuals, David and Melissa Elkins, and I just put this slide in to show that this basket of worms came from expulsion chemotherapy in a group of school children in Tamil Nadu on the coast in a set of fishing villages. And it does rather remind one that these worms cause a huge burden to individuals as they grow and go into education. That expulsion study was the beginning of trying to think of ways to measure key parameters, such as the distribution of parasite numbers per host, any density dependence in egg production and so on, and the sex ratios of male to female in dioecious species. Now, drug donations. Bill Gates, as a stimulator in part, but a set of CEOs of the major pharmaceutical companies have done an extraordinary job, actually, in these donations. And this is the set of figures up to 2016, roughly, although not complete for 16. But you can see 1.29 billion treatments were delivered to roughly 1 billion people in 2015. That's all donations, all free drugs, and it's an extraordinary track record. And long may that continue. And of course, its continuation is dependent in part on a series of strategies from WHO and also how individual governments in these endemic areas regard this as a health priority or not in the coming decades. So a really wonderful story, and long may these companies continue to donate. The coverage figure that WHO quotes, if many of you will be familiar, going onto their data websites under the NTD WHO website, the data is very patchy for different regions and different countries, and it tends not actually to include the detail that's important in this, and that is more to do with individual coverage and the frequency with which those individuals are treated. And this is equally true for LF, Onchocerca, schistosomes, and STH. So the data can be looked at and interpreted in very positive lights, but underlying this is a lot of detail that absolutely matters. Now, if we turn to the individual infections, and here we've got the helminths, LF onco, STH, SCH, and trachoma, and PC is just the overall figure of anybody who's got an infection, whether they get a pill in a particular time frame. And the detail here matters. In other words, if you look at the bottom, these are coverage figures for preschool age children, which is 2 to 4, school age children, which is 5 to 15 in WHO jargon, And you can see with STH, we've got good coverage on both, and the figures are going well. With schistosomes, we've got good coverage in SAC. You can't treat earlier than that because of lack of licensing structure for praziquantel in very young children. And then you see adult coverage at quite a low level. And I'll come back to the importance of this in a minute. So these patterns are very different for the different human helminth infections. And of course, for onco and LF, the treatment is community-wide, hopefully. Now, in the control, if you're doing this in a scientific way as opposed to a policy way, you've got 4 key tasks. The first one, for a defined setting, is to calculate the optimum antihelmintic treatment schedule. In other words, who to treat, how to treat, and so on. And it also depends on whether your target, policy-wise, is treating serious disease, in other words, heavy infection, or whether eventually your target may be trying to interrupt transmission. And both are very different strategies, and you need different requirements for each. There is a transmission breakpoint in all of these, and I'll come back to this issue in a minute. Let's try to estimate where roughly these lie. So where do you need to get worm burdens down to, or prevalences down to actually be in a position where extinction is the attractor in the system? And then, very important at the moment, particularly with LF and onco, is stopping rules for MDA. At what prevalence do you stop? And how have you estimated that prevalence given new diagnostics coming in all of these infections? And then, crucially, is to define the M&E program to both during the MDA but post-cessation. And too little thought has been given to this back end of it, and I'll comment on that later on. Now, if we're defining the breakpoints, we need to do this systematically. We need to do it for low, medium, and high transmission settings. We need to use WHO criteria for the definition of transmission intensity. That can be a slight problem because, remember, WHO's criteria here are outside of infectious disease epidemiology today, so they don't use rather important parameters, which is the basic reproductive number. It's the transmission, reproduction, and transmission intensity in a setting. We need also, and there are many different options here, there's not one solution to these problems, there are many different solutions. Who should be treated in the program, preschool age, school age, or adults, and what fractions of each? There are logistical issues here about can you get to them, and it's very understandable to focus on school age children because they are often easier in defined communities to get to. And then, given all of this, you can then, in principle, scientifically calculate who should be treated, how often, and what proportion in each of the age groups. And the point I want to make here is that this is no longer WHO committee by consensus. This is hard science. You can do these calculations. You could estimate the parameters for given field settings. So these are not, as it were, independent model theoretical predictions. They're predictions based on hard data and hard parameter estimation. And then also, there's a key issue of how long do you actually treat for. And that's non-trivial, and of course it depends very much whether you're on a low, medium, or high intrinsic transmission setting. And that's very pertinent to the donors, because how long do they have to continue the donations, and that's crucially important at the moment with LF. Now, each of the major human helminth infections have classical and fairly uniform patterns of infection. So Ascaris peaks in school-age children, decays in adulthood, and there's intensity. There's intensity and prevalence here. And remember, the top versus the bottom are related by the distribution of parasite numbers per host, and in particular, the aggregation parameter K. So high aggregation, small k, low aggregation, high k. And you've got Ascaris is similar to Trichuris. If one looks at this data, one set was collected by Mark Bradley, sitting here in Hookworm, and another set was collected by Don Bundy in St. Lucia. These were expulsion studies, so you not only had prevalence and intensity by Cato-Katz or whatever, you had expulsion of worms and counting of worms. So these patterns are fairly uniform throughout the world. There are a few exceptions with hookworm, which are less understood. They're probably due to habits, agricultural habits in given settings. So that's the STH. And of course, it's obvious immediately that a strategy for Ascaris and Trichuris, there may be a different strategy for hookworm if you do it calculation-based. Now, if you turn to schistosomes, this is hematobium, which is the more extreme bell-shaped curve than Mansoни. And this is the Bradley study in Tanzania before MDA was introduced. And so this is the pristine transmission intensity. You can see prevalence and intensity profiles, left intensity, right prevalence. And it's quite clear that these parasites are highly aggregated because of the difference between these two records. And this suggests at first sight that you focus your treatment on school-age children. But if you integrate under the left-hand curve, then you can see there's an awful lot of infection in over 15-year-olds. So if you don't treat adults, you're never going to break transmission, and you're always going to have reservoirs of infection. LF is a little bit more variable worldwide, but this would be a typical pattern from Pondicherry and Tanzania. On the right-hand side is the India map before wide-scale MDA. And you can see here that roughly in the Tanzanian setting, the force of infection is probably constant by age. And that's not surprising, given it's a vector-borne infection. In Pondicherry, there's a decline in the older age groups. This is MF prevalence, and of course, new diagnostics can change these graphs very substantially, and I'll come back to that point. The reported MDA coverage, and this is Tamil Nadu in India, which is one of the best states for public health in the whole of India. And if you look at the reported coverage from 97 through to 2001, these figures in the high 90s, do we believe that? Probably not. So in many settings, there are incentives for over-reporting, particularly if there are government staff involved. So one has to take many of these figures with a pinch of salt, and I would always argue, don't rely on the coverage data, rely on the epidemiological data of the prevalence and intensity of infection. And we know LF is still around in Tamil Nadu. Onchocerciasis, again, is one of these long duration infections in terms of the lifespan of the adult worm. And in essence, we also know that, roughly speaking, this is work by a whole variety of groups, but particularly the Erasmus group and Maria Gloria Bazanes, the force of infection is roughly constant with age. Again, it's a vector-transmitted infection. So these patterns are the first step in thinking about how MDA is done. There's another layer on that. I haven't got time to go into it, and that, of course, is morbidity. So it's laying on top of the intensity of infection and its distribution, the morbidity consequences of that. Now, I wanted to stress that demography matters as much as epidemiology, and this is an extreme example here. This is Uganda, 2011, and if at the time we're targeting both SCH and STH MDA at school-age children from 5 to 14, and if you look at the right-hand side, the top graph, the percentage of the population in that age grouping is about 31%. You turn to the bottom, which is epidemiology, and you ask how much infection is in that age group. The answer is 16%. So it's quite obvious, if you stick with treating SAC, or pre-SAC as well, you're never going to have a really significant impact on transmission. And this is the key policy issue at the moment for hookworm and STH and WHO, is whether one should broaden this to community-based treatment as for LF and onco. And to me, the conclusion is obvious. You have to broaden it. The other major epidemiological features, the left-hand side is the frequency distribution or probability distribution of worm numbers per host. And all of them, most people harbour few, a few people harbour many. Those who harbour many are more likely to have morbidity. The other principal population ecology features are on the right-hand side. The top, there's density-dependent fecundity. So as worm burden rises, the per capita fecundity for female worm falls, and that's a very important regulatory constraint, and I'll come back to what the implications of that are. And then the bottom slide, even more important in the end game of MDA, is that those who are heavily infected, every study that's looked at predisposition for helminths has found predisposition. In other words, those heavily infected reacquire heavy infection. The reasons for that are not understood. They're a mixture of genetic, social, environmental, behavioral issues. And indeed, we need to know more about that. Common modern molecular tools, by the way, are beginning to provide some very powerful ways of looking at this. Alice Easton, who's in the research group at Imperial and is now in NIH, has been doing whole genome sequencing of Ascaris, and we now have an ability to say who infects whom. In other words, we are trying to get a little bit more detail about those predisposed to heavy infection. So it's a nice example of an area that David has led that is coming in to provide very powerful new tools in epidemiological research. Drug efficacy, clearly this matters hugely, and the only thing that's important here is Tricuris, and you can see that Gates Foundation with WHO and others moving towards possible dual therapy is very, very important for Tricuris because efficacy or overall cure rate is very low with albendazole and mebendazole. It's not bad for Ascaris and it's not bad for hookworm. Both drugs offer options. Drug efficacy matters because you've got to always multiply coverage by efficacy to get what I call effective coverage. So even though you might have a figure of 80%, if it's Tricuris and you've only got a cure rate of 43%, your coverage is 40% or less, your effective coverage. Now, the breakpoint in transmission. This is a truism. It's not an abstract theoretical concept. If you've got dioecious species of two sexes, as all these human helminths are, you need both a male and a female at some time together in the host to produce viable offspring. Intuitively, it's immediately obvious the probability distribution of parasites per host matters, because if they're highly aggregated, a female worm has a much higher probability of meeting a mate. Now, as you get down to the end game, where these distributions get lower and lower, if predisposition is still important, then it means essentially there's still going to be fertilized parasites around. And the breakpoint in transmission is you've got two attractors in the system, stable endemic infection, bottom end, you've got extinction, and in between this, due to those mating probabilities, you've got a boundary that if you cross, which is not zero for the mean worm burden, but if you cross it, then you're attracted to the zero attractor. I should say that all this is relevant because acquired immunity does not appear, despite the evidence of strong immunological responses to most of the parasite antigens for helminths, it does not appear to be protective. It may have an accumulated effect in schistosomes in older age groups, but it's rather disappointing. And the reason for that is these worms secrete a lot of small molecules. Most of these small molecules of the size intruding in the cytokine pathways. So they're inhibiting our ability to develop acquired immunity. Where this breakpoint lies depends on the degree of aggregation. The more aggregated the parasites are, the lower that breakpoint is in the system. But the next stage of this is, can we calculate these things? So this is just to illustrate crossing the breakpoint. The light grey is going to extinction. The control arm is you continue MDA at less frequent intervals. This is after annual rounds of MDA for Ascaris. And then if you stop at a certain time when you've got to very, very low worm burden and you're not below the breakpoint, then the system will bounce back to its pre-control state. Now, very interesting, that bounce back time from when you stop MDA to the previous pre-control state is directly proportional to the life expectancy of the adult worm. The longer the life expectancy, the longer that bounce back time. And to give you some comparative figures, for Ascaris, everything else being equal, if you stop MDA, the bounce back time is about 2 to 3 years. If you go to Onco, with a long life expectancy of, say, 10 years plus, your bounce back time may be 20 years. And that tells you something about M&E. LF is somewhere in the middle, but more to the Onco end. Schistosomes, your probably bounce back time is 6, 7 years, something like that. So those things, which are population ecology, are very important in the design of M&E, and indeed the breakpoint, where it is very important designing your stopping prevalence. Now, modern methods in this domain, which have been in physics and engineering for a long time, this is just one example. We can take an age intensity and age prevalence curve, and we can use Monte Carlo Markov chain methods to estimate the key parameters. This is an example for hookworm. So it's estimating life expectancy, it's estimating aggregation and other parameters. If you have independent estimates of any one of these, your statistical precision is hugely enhanced. But the point I want to make here is from what we measure epidemiologically commonly, age prevalence, age intensity, with modern methods, statistical methods, we can estimate a lot of detail about the population ecology. And that's important when you start to then calculate the breakpoint. Now, I've taken an extreme example here, which is hookworm. And I've already said that most of the infection is adults. And these are 3 examples for low, medium, and high transmission settings. And on the vertical axis is the coverage in SAC. On the axis coming out to you is the coverage in adults. And the axis going away for you on the bottom is increased coverage in pre-SAC. And these, you have to be above these surfaces to have crossed the breakpoint. And what it tells you simply is that if you never, even in low transmission settings, if you never treat adults, you're never ever going to get anywhere near it. So you've always got to treat adults to get some form of transmission control. So the previous estimation procedures used in mathematical structures of the population dynamics, you can then estimate what these threshold surfaces look like. Now, that's a deterministic world. The real world is never deterministic, so you have to move on from this. And modern computational power gives you the ability to do that, is to turn all this into a probabilistic framework where you can estimate the likelihood, the probability likelihood of transmission elimination given certain coverages. Here's an example. I've got a wonderful research group at Imperial at the moment with a lot of technical skill in these areas for the stochastic models, and I'll comment later about them. And the probability of extinction by year 10 of rounds of MDA with a defined coverage, which is 50% pre-SAC, 75% SAC, and then varying adult coverage. And this is an R0 of 3, which is medium to high transmission. And you can see the proportion of adults treated affects hugely what your probability of elimination is. This is in a stochastic sense. So if your coverage is about 60%, you've only got a 0.3 probability of crossing the transmission threshold in a stochastic world. Now, to go a little bit more in detail into this stochastic world, because it is hugely important in stopping rules and the prevalence you decide to use to stop. Well, I should just add, in support of Hugo Turner, we have in the UK, he was at Imperial, now at Oxford, somebody who's been doing some very nice work on health economics. And I just wanted to make the point that laid on top of this, you can put an economic layer. And one of the most important parameters is looking at cost per treatment as a function of number of treatments delivered. So if you look at the top slide, that's cost per person treated versus numbers treated. And you can see it's a nonlinear function. And that's hugely important logistically, because it simply says that you get a lot of benefit by treating more. You get a per cost unit treatment benefit. Now, how much data is this? This is data from SCI, from Fiona Fleming, from one of SCI's programs. Hugo and I have tried to find data for this for a variety of infections, LF-onco and STH. This data is extremely rare, and it means we have to turn more attention to actually measuring it. This will be important after the donations stop and whether governments decide to introduce their own programs as the cost per doing it. Now, back to the stochastic world. Now, this is related to a Gates grant, DW3, held at the Natural History Museum, which Don here played a very important role in, which is an attempt to look in a clinical community-based trial at whether you can cross transmission breakpoints by MDA alone. Now, this just illustrates the nature of the problem. If you take a medium to high transmission setting, which is the left-hand side, and this is the simulated mean worm burden from the stochastic individual-based model at multiple rounds of chemotherapy post-initiation at time 0 in 20 communities, 100 people sampled in each of these communities. And the lower the transmission intensity, actually the more variability you get out of this, and the right-hand side is a lower or to medium transmission setting. So what this tells you is if you do a community-based trial, the outcome will vary by village, even if deterministically you're across what you calculate to be the breakpoint. So the real world is chance related. There's all sorts of issues there. Some of these heterogeneities we can measure, some we can't. And the stochastic nature of these outcomes is perhaps highlighted here for the DWORM3 study, where you start with endemic infection, STH. You have an LF program for 4 years, community coverage, loads going down. You then have the study intense period of amplifying MDA coverage, and then you have a period where you stop NDA and monitor what happens. And as you can see, in some villages it goes to extinction, green, and in some doesn't, even though deterministically you're above the level you thought would reach elimination. There are all sorts of nonlinearities in this system, and I wanted to point out this one, which is when you stop MDA, you, even in those villages where you're going to elimination, you will get a bounce back. What's the reason for that? The pool of infective stages in the environment and their lifespan. So that bounce back period is related to their lifespan. And there are some, obviously, that fail and bounce back. And what you do statistically, and again, parasitology is not good in using these methods, which are widely used in clinical trials, you use a statistic called the positive predictive value and the negative predictive value. What they are is the probability that you think you're going to elimination, and you are. The negative predictive value is you think you're going to bounce back, and you are. So these statistics can be calculated in clinical trial settings, and your ideal is that your positive predictive value is 1. That's what you'd like. You never get there, but you'd like that. You'd like to be able to absolutely predict in which villages you're going to go to extinction, and that is what the program DW3 is doing. And the next 4 years will tell us what happens. Lastly, even in a defined, this is one of the study sites which I've just come back from recently, Jawadi Hills in India, Tamil Nadu, beautiful area. Even if you take closely spatially located villages, and this is work of Rajiv Sagar, you get quite a lot of variability in hookworm prevalence. We don't understand why at all, and that's why these new molecular tools of who infects whom is going to be rather important. But you can see this heterogeneity in the design of community-based trials is a problem, so that needs thinking about. Lastly, I want to end on compliance and its importance. If you think of a spectrum, and I know this from my earlier work on HIV, where we used medication event monitoring systems to see how well patients were taking pills, and basically there were 2 ends of the spectrum. There were the compulsive obsessives who always took their pill exactly at the right time on the right day. The other end of the spectrum, there were the completely chaotic individuals who always forgot to take their pill. Now, compliance in MDA for helminths, there are similar issues. There is random treatment, so you say you've got a coverage of 70%, that you're covering randomly 70% of the population target, and it's different individuals each time, some the same, some not the same. At the other end of the spectrum, and this is the bad news domain, and I suspect more likely reality, is 70% coverage. It's the same 70% you treat at each round, and it's 30% who are the persistent non-compliers. So getting to either morbidity or transmission control will depend on what pattern of compliance there is. Nobody has measured this longitudinally well, except the recent Tumikia study in Kenya, and that data is just being analysed at present, and our reserve judgment, but I suspect it's more to the right end than the left end. Which programs does WHO record compliance? Do major STH or schistosome or LF or onco programs report compliance individually over time? The answer is no. The data, a recent review by Katie Schulford, published in Parasites and Vectors, showed the quality. There were thousands and thousands of studies that mentioned compliance, about 2 that did individual longitudinal data. And the effects are staggering. Here's just an example of the 2 extremes, random coverage and systematic compliance. Your probability at year 8 with a given level of coverage of extinction. And for the random coverage here, look at the difference between that and the systematic non-compliance. So it matters enormously about what the outcome is. Now, just to end, I want to end on what the future holds, because Russ asked us to think about future changes. And I'm going to say something quite controversial here, and I can't give you the exact results because they're under press at the moment, and they're not my data. The Gates Foundation and NIH have been supporting a program on schistosome vaccines, particularly S-MANCINI. The results that have been through primates, which are baboons, good model for S-MANCINI, are staggering, and I'll just leave it at that. The problem today in vaccine development is not science, it's not platforms. It is a financial model that will persuade a company to manufacture a schistosome vaccine. And that problem is not solved. If we solve that problem with first into humans on this vaccine in the coming 12 months, it then probably would take 6 to 7 years to go through phase 3. Phase 3 will cost $300 million plus US dollars, and it's persuading a company that having spent all that, they can then recover their costs at least from actually selling the vaccine. Hookworm and Ascaris, probably Onco and LF, the science technology platforms to do these vaccines are there today. So it's not a matter of science, it's a matter of economics and business proposals construct. Lastly, I haven't mentioned diagnostics, and I must. A lot of diagnostic people in the room, and I should just say that qPCR and CATOCATs are changing the landscape. Here we see, this is work of Alice Easton, who did a PhD at Imperial, now in NIH, and just accepted a faculty post at NYU. 46% more positive samples when diagnosed with qPCR. They're all at low EPG. Wonderful linear relationship with Ascaris for qPCR and CATOCATs, except when you get to low CATOCATs. Then you're missing a ton. And when we're looking at endgames and prevalences and so on, we clearly have to turn to these new diagnostic tools. So conclusions, just to end. For most of these helminths, we have to treat adults, and LF and Onco are good learning lessons for that. It's more challenging logistically to do, and that we have to recognize, and more costly to do. I come back to the point I made earlier that parasite epidemiology, helminth epidemiology, really needs to catch up with other areas of viral and bacterial epidemiology. We don't have to make judgments by verbal argument. We can do calculations today, and those calculations are based on population ecology. There are still many areas of uncertainty, and I only touched on a few, in other words, compliance, diagnostics, and so on. There are a ton of others, like trying to explain for that India study site why there's so much variance between villages that are spatially next to each other. How do we understand that? And there, the molecular genetic methods may provide all sorts of opportunities. And I return to compliance, 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 rather like education, 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 is key to all of this. And we need to encourage WHO and countries to measure this more precisely in the future. And then I hadn't had time to go into detail to monitoring evaluation, but the simple answer is it's better to do a few sites very well and cross-sectional than all sites badly, many sites badly. I'm very privileged at Imperial to work with a wonderful research team, all of whom contributed in different ways to this, and it's been a great privilege working with them on it, and we're on a journey to do a lot of other things. And I must acknowledge CMC in Vellore with Rajiv, who did a wonderful job in the basic epidemiology of hookworm in Vellore. And then Judd Wilson, who's the PI on DW3 in Seattle, is always a great stimulus to these projects. But coming back to David, I rather hope that our genome sequencing efforts in helminthology will lead to answering some epidemiological questions. And it's been a real privilege to be here today. Thank you very much indeed.